The risk of famine is high and increasing each day with persistent hostilities and restricted humanitarian access. Every person our teams talk to asks for food and water. Decisions by various countries to pause funds for UNRWA, the largest supplier of humanitarian aid in this crisis, will have catastrophic consequences for the people of Gaza. No other entity has the capacity to deliver the scale and breadth of assistance that 2.2 million people in Gaza urgently need. We appeal for these announcements to be reconsidered, and we continue to call for safe access for humanitarian personnel and supplies. And we continue to call for the hostages to be released. We continue to call for healthcare to be protected and not attacked or militarized. And we continue to call for a ceasefire. Last week, WHO Executive Board met to discuss many aspects of the organization's work. Among other issues, the board reviewed WHO's global strategic plan for the next 4 years and approved the first WHO investment round, which we will hold later this year, and which aims to generate more predictable, flexible, and sustainable funding for WHO's work. Member states also discussed WHO's work on health emergencies, including pandemic prevention, preparedness, and response. They expressed strong support for the pandemic agreement and amendments to the international health regulations, and emphasized the urgency of concluding negotiations in time for the World Health Assembly in May of this year. It's vital that member states meet that deadline. Yesterday, a group of more than 40 global health leaders published an open letter calling on world leaders to show leadership, urgency, and commitment to conclude a pandemic agreement that transcends business as usual. I echo that call. One of the main purposes of the agreement is to improve equitable access to vaccines, tests, treatments, and other products. During the COVID-19 pandemic, WHO established COVAX and the COVID-19 Technology Access Pool, or CTAP, to facilitate sharing of intellectual property, knowledge, and innovations. COVAX closed at the end of last year, and today we are pleased to announce that CTAP will become the Health Technology Access Pool, HTAP, with a broader mission to expand access to life-saving tools for COVID-19 and other priority diseases. We are also pleased to announce that WHO and the Medicines Patent Pool have agreed a license agreement with the company SD Biosensor for the rights, know-how, and material to manufacture its rapid diagnostic technology. Also discussed at last week's executive board was WHO's work on non-communicable diseases, including cardiovascular disease, diabetes, and cancer. One of the most important actions countries can take to prevent this disease is to eliminating the things that cause them, including tobacco and trans fat. Industrially produced trans fat is used in many food products. It has no known health benefit, but carries huge health risks. 5 years ago, WHO launched a campaign to eliminate industrially produced trans fat from the global food supply. So far, 53 countries have introduced best practice policies, including bans or limits on trans fat, with 3 more countries on the way. However, introducing a policy is one thing. Implementing it is another. So last year, WHO launched the process to recognize countries who are going beyond introducing policies to monitoring and enforcing them. On Monday, we validated the first 5 countries who are leading the world in implementing their policies on trans fat elimination: Denmark, Lithuania, Poland, Saudi Arabia, and Thailand. Congratulations to these 5 countries, and we look forward to more countries joining them. Finally, yesterday marked World Neglected Tropical Disease Day, and Sunday was World Leprosy Day. Neglected tropical diseases or entities affect more than 1 billion people around the world, especially in poor and marginalized communities. But entities are preventable and in many cases can be eliminated completely from countries. So far, 50 countries have eliminated at least one entity. And we are on track to reach our goal of 100 countries by 2030. But medical interventions are not enough. We must also address the conditions in which these diseases thrive, including stigma and discrimination. This year, the theme for World Neglected Tropical Disease Day is Unite, Act, Eliminate. One of the oldest and most misunderstood diseases in the world is leprosy. The world has made great progress against leprosy. The number of reported cases has dropped from an estimated 5 million a year in the mid-1980s to about 200,000 cases a year now. Although it has now been curable for more than 40 years, it still has the power to stigmatize. Stigma contributes to hesitancy to seek treatment, putting people at risk of disabilities and contributing to ongoing transmission. Eliminating leprosy therefore requires not only renewed political commitment and access to services to treat it, but also awareness raising to mitigate stigma and increase social participation for those affected by leprosy. One of the world's leading advocates for leprosy elimination is Mr. Yohei Sasakawa, the chairman of the Nippon Foundation and WHO's Goodwill Ambassador for leprosy elimination. Mr. Sasakawa has dedicated his life to ending leprosy and promoting human rights for those affected by the disease. Later this afternoon, I will join him in launching the global appeal to end stigma and discrimination against persons affected by leprosy. Sasakawa-san, thank you for your dedication to this cause. Arigato gozaimasu, and you have the floor.
Dr. Tedros, thank you for your kind introduction. As you know, leprosy is not a curse nor a punishment from God. It is a weak infectious disease caused by leprosy bacillus that can now be cured with drugs. In many countries, leprosy tends to be considered a disease of the past. In fact, it still exists. There are large pockets of cases, both registered and hidden in more than 100 countries around the world today. Another aspect that we cannot ignore is discrimination. Since Old Testament times, persons affected by leprosy and their family members have faced extremely harsh discrimination. It is a very serious human rights issue. Over the past 50 years, I have visited leprosy endemic areas in over 120 countries. Everywhere, I met with countless number of people who have been abandoned, not only by society, but even by their own families, living in despair and in solitude. While I have dedicated my life to achieving zero leprosy, to free persons affected by leprosy from such pain and suffering, unfortunately, I am only halfway there. So, what can we do to help achieve zero leprosy? The answer lies in active early detection and prompt treatment. However, persons affected by leprosy are hesitant to visit medical facilities because of painless early symptoms and fear of discrimination. As a result, the disease progresses, leading to serious physical disabilities. We must, therefore, not wait for patients to self-present themselves. We need to carry out extensive door-to-door campaign to find the hidden cases. Now that the drugs are available, free of charge worldwide, and the coronavirus is no longer a global health emergency, I believe it is an opportune time to give another strong push toward zero leprosy by strengthening active case detection and prompt treatment. Dear friends and colleagues, zero leprosy is not an impossible dream. I ask for your further cooperation so that together we can make the impossible possible. Thank you very much, Dr. Tedros.
Thank you so much. Again, arigato gozaimasu. I think, as I fully agree with you, that zero leprosy is not impossible. So let's make the impossible possible. I'm with you. And thank you so much for your lifelong commitment, more than 50 years. That's clearly a lot. And that shows your commitment to those people who need support globally. By the way, you said you're halfway. You're more than halfway.
Yeah.
Because in the 1980s, that's around the time you started, it was more than 5 million cases. Actually, 10 to 12 million estimate also from others. And now we're around 150,000, I think. That's a big progress. So thank you so much for your leadership and commitment. And thank you once again for your commitment to fighting this disease, as well as especially what you said, the stigma and discrimination. And thank you for taking it not just as a health problem, but as a human rights problem as well.
Yeah.
So arigato gozaimasu. And Christian, back to you.
Thank you very much, Director General. Thank you much, Mr. Sasakawa. I'd like to encourage questions from Mr. Sasakawa first, but because we're not sure how long he can stay due to the upcoming event this afternoon. So again, if you want to come into the line and ask your question, please raise your hand with the raise your hand icon. And with this, we start with Banjot Kaur from the Wire in India. Banjot, please go ahead and unmute yourself.
Hi, thanks for taking my question. My question is on leprosy. as you spoke about stigma and which is particularly associated with leprosy, India has also had leprosy elimination program for quite some time now, and has made some progress also. But from India's point of view, if you could highlight what are the specific areas that the country needs to do more so that the required progress can be achieved, and where are the areas that we should have done better by now and we actually couldn't do so, the country couldn't do so.
Thank you, Ahmed Panjat, and we'll give to Mr. Sasakawa.
素晴らしい質問をいただきましてありがとうございます。世界中で今レプロシーの制圧活動が最も活発なところは実はインドで、ございます。そして約850のコロニーと言われるハンセン病の回復者とその家族が住んでいるところを我々はしっかりとサポートをいたしております。何よりもこの偏見差別の問題は2010年に国連で全ての加盟国が参加してレプロシーの患者回復者その家族に対する偏見差別の撤廃の決議がされましたけども残念ながらまだ十分に私たちの活動が役割を果たしているとは言えません。さらなる我々の啓蒙活動が必要だと思っておりますがインドにおきましてもまだ130ぐらいの差別法も各州で残っておりますのでこの解決も私たちは急がなければいけないと思っております。お答えになったでしょうか？
Banjot, I think we're good. Thank you very much. And with this, we go to Catherine Fioncan from France 24. Catherine, please go ahead and unmute.
Yes, thank you, Christian, for giving me the floor. Good afternoon, all of you. Sorry, I'm going to stop my translation. Yes. My question is related to and particularly from all the 6 WHO regions, I would like where Africa stands and what you can tell us about the fact why is the reasons why leprosy is so common in Africa.
So maybe we could start with the why leprosy is so common in Africa with Mr. Sasakawa and then Dr. Sosifol for the action of WHO. Yeah, Mr. Sasakawa, please. Why is leprosy so prominent in Africa?
入ってない。はい。アフリカに限りません。東南アジア、そして、ブラジル、南米におきましても、まだ残念ながら隠れた患者さんがたくさんいると推定をいたしております。私はコロナも一段落しましたので、このアフリカはもちろんのこと、東南アジアそして、ブラジルに対しましても各地域を回って、患者の発見とそして、偏見差別の撤廃の活動をさらに強力に進めていきたいと考えております。
Thank you. Thank you. And for Dr. Sosifol, please.
Thank you, Christian. Catherine, thank you for the question. First of all, leprosy is a global problem. I think we all heard from Dr. Tedros, Mr. Sasakawa, talking about the number of countries affected. So we have more than 100 countries affected, and some big countries outside Africa, like Brazil, India, also so affected. We need to take it, in the context of poverty and difficult access to basic services. So all vulnerable populations in the world are at risk. But making sure that in every single country, we have all the means to detect cases, to investigate around them, do contact tracing, and, post-exposure prophylaxis is a way to reach zero elimination. It's like what we are doing for outbreak control. And so we need to use the opportunity of the capacity we have built for outbreak control and pandemic to really accelerate leprosy elimination, because we are targeting zero transmission. So it's a global problem, but every region, every country need to take specific action, but also create conditions for access to, primary health care and universal health coverage. We cannot talk about universal health coverage in any country if we cannot provide services to prevent and treat people who are affected by leprosy. Thank you.
Thank you very much, both. We have one written question from BBC News Kinshasa, Emery Makomeno. Can you elaborate on the 2030 objectives to end neglected tropical diseases in general, especially what has been deployed to deal with the rest of countries still grappling with tropical diseases, mainly in Africa? I guess this is for Dr. Sosifo.
Thank you very much. So the global roadmap for NTD elimination is a blueprint for all countries and partners, targeting disease elimination by 2030. Some of the diseases are targeted for eradication, meaning stopping transmission worldwide. And leprosy is one of them. Guinea worm also is one of them, and yours. But we have other, targeted intervention where we want access to treatment and reduce the number of people who need NTD's intervention by 2030. And so we are talking about 1.6 billion people who needs intervention, not only in Africa, but worldwide. It means that we need really to take a more horizontal approach while dealing with NTDs, because the same people are at risk for so many other diseases, including epidemic-prone diseases, but also non-communicable diseases and mental health, meaning that strengthening the health system is the way to go to make sure that those people that are difficult to access have access to primary health care and can be referred to, secondary or tertiary services when needed. So we need a real global approach, but we have platforms to make sure that entities are not neglected anymore. We have the platform of universal health coverage and primary health care. We have the platform of pandemic preparedness and response. We are talking about climate change affecting so many entities. The One Health approach dealing with animal health, human health, and environmental health. So we shouldn't see entities in isolation, but in the context of the real health system able to deliver critical services to the people who need the most. Because if we can't deliver, some critical services for entities for people who need them, we cannot dream about universal health coverage. Entities should be a real tracer for universal health coverage. And this is in this context, we are working with all the program in WHO, but also with so many other partners. But we ultimately need countries to be on the driving side. The country leadership and commitment to make sure that domestic funding are also secured for entities, as we do for other programs, will be extremely important. And global partners also with specific funding mechanism need to leverage those funding to be able to cover cross-cutting areas like supply, like surveillance, and so many others. Thank you.
Thank you very much, Dr. Sosifal. He's director for the WHO Global NTD program. Next question goes to Bafana Busani from Interpress. Bafana, please unmute.
Thank you. My question, I have two questions. My first question goes to Dr. Tedros. Despite the advances in global medicine, why is it that we are still failing to completely eliminate leprosy? is there a need for new push, both for research funding or political action? And then I also have a question for Mr. Sasakawa. You've been doing this campaign for a good past 75 years. Are you convinced that public awareness is the single solution that will work towards eliminating discrimination for persons affected by leprosy? Thank you.
Thank you very much. And we start with the Director General.
Yeah, thank you. As I said in my speech, in the 1980s, the number of cases was 10 to 12 million. And now we have 150,000 annually, which is a significant, actually, reduction from where it was. It means what we're using actually is enough. As Mr. Sasakawa earlier said, the medicine is available and it's actually free. But the question you asked is, why are we not, eliminating the disease fully? The target which we are now setting with this appeal, zero disease, zero disability, and zero discrimination, why can't we reach there? The reason is related to stigma and discrimination. That's why the launch today is very important, because of stigma and discrimination, many are not coming forward because of fear of stigma and discrimination, and they're not presenting themselves, meaning we're not detecting early to treat them. So if we can fight stigma and discrimination, then I think taking it to zero disease, zero disability, and zero discrimination would be possible. And that's why the mobilization is important. As you rightly said, also political commitment will be very important in countries to do this. And people should also understand that this is actually needs a lot of, a lot of effort to be this disease needs a lot of effort to be transmitted from one person to the other. It's not easily transmittable. People should not treat it as in the past as very infectious or easily transmittable. But not only that, more importantly, the reason behind the stigma and discrimination is, in many countries, there are still people who believe that this is either a curse or punishment, but it's not. It's a bacterial disease that can be treated easily. That's not actually transmittable easily, but that can be treated easily. So the key is in the political commitment. The key is in fighting stigma and discrimination. The key is in the public understanding this and helping. And the key is the early detection and treatment. So with that, we can take it to zero. The tools are at hand, as Mr. Sasakawa had already said, and today's event is to say exactly that. Thank you.
素晴らしい質問ありがとうございました。このレプロシーという病気は病気の中でも大変珍しい病気でございまして、初期の段階では痛みがないんです。痛みがあれば必ず病院に行くんですが、痛みがなくて体に小さなパッチができるだけなんです。その段階で病院に来てくだされば薬はタダでございますし、障害もなく治るわけでございますが、そのパッチがレプロシーの初期症状だということになかなか皆さん気づかない、痛くないために。そして障害が手足に出始めて初めて病院に来るわけですし、中にはやはりこの人に知られたくないというために、行かないために どんどん障害が進んでしまうという、そういう病気なんですね。ですから、何よりもやはり私が今世界中で活動をしていることは、メディアの皆さんのご協力をいただきまして、そして直接リモートエリアに住んでいる方々に対して特にラジオを使いまして、直接的に今あなた方の体をスキンチェックしてくださいと。体に白い斑点があったら、それはペンのようなもので刺して痛くなかったら、これはレプロシーの初期症状ですよ。すぐ病院に行ってください。薬はただですよということで、直接人々に訴えるために、やはりメディアの協力を私は世界各国で今いただいておりますけれども、大変これが有効であるということが分かっております。メディアの皆さんのご協力をいただければ、本当に WHO が目指すゼロレプロシーは難しい問題ではありません。薬がタダであること、そして条件は整っております。どうしてこれを正しくすべての人々に知っていただくかということが最大の問題でありまして、これを解決すること、ゼロレプロシーは決して夢ではありません。
Thank you very much, both. With this, we go to Belisa Godinho from W Magazine. Belisa, please go ahead and unmute.
Thank you. I'm Belisa Godinho from W Magazine, based in Lisbon, Portugal, of Global Broadcast. My question is, how can people and health service in Portugal and other parts of the world benefit from the health technology access pool? Specifically, is it planned to be implemented globally in the public and the private health sectors? Can you talk a little more about the subject? Thanks.
Thank you very much, Belisa. I guess this is a question for Michael Ward, our specialist on W Technology Access Pool. Michael, please go ahead and unmute.
Thank you, Christian, and thank you for the question. In fact, yes, we are going to be interacting with publicly funded research and development institutions. The licenses that we were able to secure, mostly under CTAP, came from such organizations, such as NIH or the National Research Council in Spain and others. But importantly, the announcement from Dr. Tedros today is from the private sector and a global leader in vitro diagnostics. So we, of course, will be reaching out to both sectors, but importantly, it's how we will do it, which will be focused on WHO priorities and a rigorous business case assessment that looks at the access gap, looks at partnerships that need to be established, works with other WHO technical units, and has an end-to-end solution. So we learned a lot from the CTAP experience, and that will be applied to the Health Technology Access Pool, which maintains an anchor in pandemic preparedness and response, but also at the same time looks at other priority diseases. And we will do this in part by acquiring technologies, supporting their development and diversified production, technologies that are platform technologies, such as the RDT technology that is announced today under license through the Medicines Patent Pool. Thank you.
Thank you very much, Mike. Next is Imogen Foulkes from BBC. Imogen, please go ahead and unmute.
Hi, thanks very much for taking my question. I'm afraid it is going to be about the Middle East. not about leprosy. Dr. Tedros, could I have your reaction to the events in Jenin Hospital yesterday morning? And second, the UN agencies, including your own, are having to face a lot of accusations. I'm thinking in particular on Friday, I think Israeli diplomats accused the WHO of colluding with Hamas. And I just wonder how concerned you are that the space for debate about what aid agencies do is getting very challenging. Thank you.
Thank you very much.
Imogen, you'll have to put up with me. Yeah, no, I think your question is well asked, and I think the challenge we all face now is that the humanitarian space is very constrained. Every aspect of what the agencies and the NGOs are trying to do is constrained. We're constrained on bringing assistance in across the border. We're constrained on how we store it. We're constrained on how we can distribute it, with so many distribution plans being denied or being impeded. We're constrained in that the number of health facilities that are operational is reduced, and they're operating much, even the ones that are working are operating at a much more reduced rate. Anything that affects any part of that, the system is so fragile right now. The connections between procurement and delivery and transport and transshipping and storage and delivery and being able to deploy emergency medical teams, supply them in the field, support them in the field, the ability to move patients. We have, as Dr. Tedros referred to, we have donkey carts moving, heavily traumatized patients. The system is so fragile that any further constraint to that system, be it financial, be it any piece of that system being constrained, further pressure on the border, further pressure on the medical staff in the hospitals, further pressure on the supply chain, fear in the hospitals and fear amongst the doctors and nurses that they may be targeted at any time, that they may become wrapped up in another piece of the conflict, be it in militarized use of the facility and be it in extrajudicial killings. Whatever it is, the health workers are operating in that frantic, that terrorizing environment, and they're trying to do less, more and more with less and less. So this is one of these situations where the straw that breaks the camel's back. We don't know where the point of failure is. There are so many points of failure in the system, and they're being pushed and they're being pressured. And one can argue that this is an accidental outcome of war, or are these points and these weak points in the system of delivery of aid being pressured and being manipulated and being turned on and off at will in order to become part of the overall conflict. And that for us is the hardest part. We are apolitical. Our job is to get the job done. Our job is to work with partners. Our only interest is the health and welfare of civilians in Gaza, in the West Bank, in Israel. What we've seen is horrific attacks on all sides. We have seen civilians bear the brunt of that. We have seen health facilities and health workers attacked on both sides of this conflict. We have seen a disproportionate use of force that has resulted in the health system's collapse in Gaza and tremendous number of casualties, tremendous number of deaths. We collude with no one. We cooperate with NGOs. We cooperate with doctors and nurses on the ground. We cooperate with our sister agencies and NGOs. Claims against WHO of collusion are false, they're harmful, and they endanger our staff in the field. Most importantly, endanger our staff in the field. We want and we will remain open to discussions with all sides on how we can improve our performance, because all performance can be improved. But the space for the UN to operate has been constrained and constricted to a point where it is impossible to deliver on all that we want to deliver on. We work towards the health and well-being of all peoples in all situations. It really is time for the international community to take a step back here, because what's happening in terms of nutrition, you only have to look at, sometimes we're asked, we were discussing here beforehand, the metrics on nutrition and what are the metrics and how many people are this far gone in terms of nutritional status and what stage they're at. You only have to look into the faces of the people and the cameras and the TVs every night, and to see how the nutritional status of people in Gaza has gone down and down and down. They are desperate. We talk about desperate people taking food off trucks. What would you do in that situation? Your family is starving, you're starving. This is a population that is starving to death. This is a population that is being pushed to the brink, and they are not parties to this conflict. And that is at the core of this. They are not parties to this conflict. The civilians of Gaza are not parties to this conflict, and they should be protected, as should be their health facilities. That is our only interest in this. And I believe that the international community need to reset our expectations in this response and reset the behavior of all parties in this conflict.
Thank you very much. And Dr. Tedros?
Yeah, thank you. I think Mike covered it. I just have to say a few words. The accusation of collusion by the ambassador is really irresponsible, because as Mike said, it could put our staff in danger. But I would like to assure the ambassador that there is no collusion, and WHO refutes any accusation. We're impartial and we're doing our job, and if there is anything we're saying also, in addition to the support, is this problem will not be resolved by force. Anyone who is, wishes well for Israel and Palestinians would advise that a lasting solution be found. That's actually something that we believe could help both the Israelis and Palestinians to live in peace. Other than that, our support is to those who need our support badly, and we will continue to do that. So thank you, and Christian.
Yeah, thank you very much, Dr. Tedros. Next goes to Yuri Aprilev from RIA Novosti. Yuri, please go ahead.
Yes, thank you. I had the same question about Jenin. If Palestine contacted the WHO about it, I'm talking about what happened in the hospital Ibn Sina in Jenin yesterday. If you have anything from Palestinian side on that, if you are talking with Israeli side on that, and is it normal? Is it something that was seen in these conflicts, that some operations, military operations like this, with special forces have taken place in a hospital?
Yuri, thank you. You were a bit broken at the end, but I think we got the gist of it, and I think we should try and get to Dr. Richard Pippercorn, our WHO rep in the occupied Palestinian territories. Rick, are you online?
Yes, I'm online. Can you hear me?
Yes, all good.
Okay. Yeah, I think it's a complex question, and so we base ourselves on reports. So let's just first focus on what we got reported when it comes to this attack on Ibn Sina Hospital in Jenin in the West Bank. So it was reported, and later we saw this also in the news, that the Special Forces operation actually went into Ibn Sina hospitals, and one person, allegedly a patient, and two companions were killed. Now, we've seen the videos, and you must have seen the videos, where the person who carried out that operation disguised himself as health workers and civilians. There was also further reports of assaults against the medical security teams in the facility during the incursion. And what we should, I think, all realize, and again, I'm not an expert, I'm a medical doctor and a public health expert, and learning more and more about international humanitarian law, unfortunately. But the use of health assets for non-health purposes is considered an attack on health. And it creates a sense of fear, and it's dangerous for health workers and patients. It also reduces the trust in health workers, the hospitals, and the system, the health system at large, and it puts them in danger. And related to them, actually decreasing the people access to care. So I think what we reiterate, and I think WHO has done, the DG has done it, I heard this from Mike many times. So we reiterate the call for active protection of civilians in healthcare and respect for the fundamental human rights and international law. Over to you. And maybe let me add something what Mike just raised, and I think we should maybe also focus a little bit more on that and what's happening in Gaza right now about the so-called shrinking humanitarian space. Unfortunately, not so-called. So just let me give you some data. In January, WHO planned 15 missions, medical supplies, food, fuel, etc. And from these 15 missions, 8 got denied. So 8 were denied. To the north, 15 to the north, this is only to the north. 8 got denied, 3 were impeded and partly impassable roads and postponed and delayed. And 1 was facilitated and 2 partially facilitated. Now to the south, in the same January, which you would say that's easier, that should happen all the time, 7 planned missions to the south, 3 were facilitated, 2 partially, and 2 denied. Now this should be the real issue. I think all those missions should have been facilitated because we try to do our level best, as we provide minimal assistance and much more is needed. So all these delays, etc. We heard about the mission just with the DG was referring to just 2 days ago to National Medical Complex. The mission was intended to bring medical supplies to National Medical Complex and food. It was agreed that food would go very early to make sure that food can actually reach the hospital for the patients and for the staff. Then that was not allowed and it would be delayed, etc. Then the food transport didn't happen. So medical supplies only. The fuel, which was done by UNRWA, was also postponed. The next day, again, so this is an enormous amount of work to every time plan it. The next day, another plan to bring in the food. Again, very early, 6 o'clock start, etc. Team ready to go. Then just 500 meters before the checkpoint, it gets halted, cannot go. Delay. Crowds come around the food truck. A lot of, I think, very good from our team trying to convince the crowd, hey, this is food for the hospital, etc. And 1.5 hours they could actually convince this, etc. And then people are indeed what Mike said, so desperate. I've been there a couple of weeks. I'm going back to Gaza next week, etc. People are desperate. So then finally the food truck was taken by the people, etc., who were completely desperate and hunger. I want to stress this point, and this is where member states should focus on. It's the dismantling of health services, which we know happened in the north of Wadi Gaza, and you see it now happening, and we've been warning constantly about this. We're now talking about how difficult it is missions to go to Khan Yunis. We call the middle area. The moment there are military activities around a hospital, National Medical Complex, which is, by the way, the Shifa of the south, together with European Gaza Hospital. So this is how important it is. The moment there are military activities, patients cannot reach the hospital anymore, ambulances cannot go, WHO cannot deliver the supplies, etc. And very quickly, a hospital becomes from partially functional, it becomes minimal functional, barely functional. At this hospital, National Medical Complex, only a couple of weeks ago when I was there, it served over 1,000 patients. Currently, 400 patients. It had hundreds of staff. Currently, it has only a few hundred staff, and most of them are volunteers. It was actually helping the field hospitals and other hospitals around. It was the prime referral hospital. Now it has to refer patients to a field hospital close by, which is very difficult as well because of the military activities. And this is what we mentioned constantly. We see a breakdown of health services constantly happening. So not only I'm not even talking about an attack on a facility, but when military activities get close to a facility, this is what's happening. And we cannot afford to lose Nasser Medical Complex, nor the European Gaza Hospital, nor Al-Aqsa Hospital. And this is where member states should focus on the protection of health service and making sure that humanitarian supplies can reach those hospitals all over Gaza. Thank you. Over to you.
Thank you, Rick, and all the best wishes to you and the colleagues there. We have time, I think, for one last question, and that goes to Mohammed Iqbal from Anadolu. Mohammed, please go ahead.
Yes, thank you so much, Christian. My question is also about the famine in Gaza. Palestinians in the north of Gaza Strip eat animal feeds to survive. There is also great famine in all Gaza. Israel prevents humanitarian aid for this region. What health consequence might this have? Could Gazan people face a humanitarian catastrophe due to hunger or famine? Thank you so much.
Thank you very much, Mohammed. We go to Dr. McGrane.
Yeah, I think I'd like to be sitting here today saying that the Palestinians in Gaza face a catastrophe. The Palestinian people in the Gaza are right in the middle of a massive catastrophe. Whichever way you look at it, in terms of nutritional status, shelter, access to clean water, access to electricity, access to medicines, it doesn't, whatever parameter you apply, this is a catastrophe. But if you're asking if the catastrophe can get worse, absolutely. And nutrition underpins every aspect of our health. It doesn't matter if we're talking about leprosy, as we're talking about today, infectious diseases, susceptibility to chronic diseases, so many factors, basic health and nutrition. And it's not just the amount of calories you eat, it's the quality of those calories. So we're not just talking about food, and we're talking about the quality of the nutrition on both fronts. The calorie count consumed by Gazans has dropped systematically, and the quality of that nutrition has dropped. And populations are not supposed to survive on food aid for months and months and years. It's supposed to be emergency food aid to tide people over while the agricultural system recovers, or while the fishing system recovers, or while the importation system recovers. In this situation, there's no prospect for any of those to recover right now. So certainly nutrition has a major impact on the immunologic system, and particularly in children. And if you mix a lack of nutrition with overcrowding and exposure to cold through lack of shelter in children, you can create conditions for massive epidemics. And we're seeing that with acute watery diarrhea, we're seeing hepatitis outbreaks, we're seeing huge numbers of pneumonia cases amongst that. So the population are experiencing all of this. Teresa might want to comment, or Rick, on some of the actual metrics regarding the severity of that. But the last major assessments were done were pretty bad, and the current assessments that are underway, I don't predict them to get any better. So nutrition has become a major issue. Dirty water, a major issue. Shelter, an absolutely incredibly major issue. Access to medicine, access to health. And our ability then, when children become very ill with and require medical feeding, we don't have the capacity. We can save many, many children in clinical feeding programs. So even in the worst of famines, you can save a lot of children if you have the right intervention at the right time. Imagine in this situation with the overcrowded hospitals, with no access to medicines, with doctors and nurses completely overwhelmed. How many of those children do you think they can save? Very, very few. So maybe Teresa, I don't know, Christian may want to supplement with numbers, or Rick may want the final word on that.
Yeah, exactly. Let's start with Dr. Zakaria, please.
Thank you, Christian. Thank you, Mike. perhaps just on the numbers, since back in December, we know already that 90%, so it's over 2 million people in Gaza are already extremely food insecure. It means that they're not eating sufficiently in quantity and in quality to maintain their health. What we're seeing now is that people have coping capacities. Their health status, however, is going to continue to deteriorate until they become sick. By that, a continuous lack of food, and again, in terms of quantity as well as quality. What is most concerning is this lack of nutrition for a long period of time among children, especially those who are under 5, because when they reach the stage of acute malnutrition, then they are at imminent risk of dying. So we don't want to reach this. Gaza is not a territory that had problems with acute malnutrition among young children. And we cannot reach this stage where then children are at imminent risk of dying because they're not getting the food that they need. Thank you.
Thank you, Dr. Teresa Zakaria, and Dr. Papercorn wanted to come in.
Yeah, well, thank you very much, Christian. And I think it's a very important questions and comments. I want to comment on 2 points. I'm not an agriculture specialist, but I learned a lot from my colleagues from FVO and WFP. So first, a very pragmatic point. And I think you should, as journalists, also raise this with WFP. According to the information we get, WFP actually have almost sufficient food and food supplies to actually cover the larger population of Gaza. It's all about getting this food into Gaza, making sure that the humanitarian activities can work. So you need more trucks, you need more transport facilities, and to make sure that it can be transported all over Gaza. So the understanding is that actually it's there. It's mainly a logistical problem outside and within Gaza. That is one. The second one is visiting Gaza every month. Gaza is in a large part was self-sufficient when it comes to meat and poultry, when it comes to eggs, when it comes to vegetables, when it comes to fruits, really good fruits and vegetables, and fish as well. That was all there. What I understand that millions, like 30 million chicken, are not there anymore. So the whole agriculture and agri-food activities have actually collapsed. Now, how could we strengthen that? To that get back. A link to that is, of course, the private sector, which is being constantly raised by the humanitarians to make sure that you cannot be reliant on a humanitarian initiative, how large it is. You need the private sector to get back into action and back into on their feet. Why is that not happening? Those questions should be raised. Those questions should be pushed, and that should be changed. And there is the IPC report. There is a review going on, and like Mike Ryan, I'm also not very optimistic about that review. But I will listen to the experts. It should come out somewhere mid-February. Again, make sure that WFP goods can come into Gaza and can be distributed everywhere, and make sure that the agriculture and the agri-food and the fishery, etc., can start up again. Because that was there, that was Gazan, and that was working. Thanks.
Thank you very much, Dr. Papercorn. And now we're coming to the end of our press briefing, and before I give the words to Mr. Sasakawa for some final words, let me just remind everyone that we will send the closing remarks and the sound and video files soon after the briefing, and then the transcript will be available tomorrow. I understand that we had a bit of a sound problem before, so the recordings should solve this. But first now to Mr. Sasakawa for some final remarks. Thank you.
ありがとうございます。これからWHO とともにハンセン病をゼロにする、そして偏見差別をなくすというグローバルアピールを発出するわけでございますが、ハンセン病は過去の病気ではありません。 現在進行形の病気であります。しかし、この病気は数多くある病気の中でも珍しい病気の一つでございます。なぜならば、病気には痛みが伴います。あるいは熱が出ます。従いまして病院に行こうということになるわけでございますが、レプロシーは初期段階では体の一部に白いパッチができるだけで熱も出ません。痛みも出ません。従いまして病院に行くことに患者さんはならないわけでございます。そして病院に来た時にはすでにこの手や足に変形が出た段階で来るということになるわけでございますし、この世界中あらゆる国でこのレプロシーという病気が偏見差別を受けている病気でございまして、決して過去の病気ではありません。これをWHO としては制圧をしたいわけでございまして、そのためにはどうしてもメディアの皆さんのご協力が必要でございまして、この病気の特殊性というものをメディアの皆さんにもご理解をいただきまして、今や隠れた病気のように思われておりますが、メディアの皆さんのご協力さえいただければ薬はタダでございますし、WHO が描いているゼロとすることが可能になってまいります。私も世界中現場には問題点と答えがあるということで、これからも世界中現場に行って、活動をいたしますが、どうぞメディアの皆さんのご協力をお願い申し上げます。
Thank you very much, Mr. Sasakawa and Dr. Tedros for closing.
Thank you so much. Again, Ambassador Sasakawa, more than 50 years of commitment and visits to more than 120 countries is really, great. And thank you so much for your lifelong commitment. And you're saying I'm not tired yet, still I want to finish the job. And I would also like to thank you for your continued leadership and commitment. That inspires me personally as an individual. That kind of focus, persistence, perseverance, and continued commitment. And it also inspires many colleagues here. And thank you so much indeed for supporting especially leprosy patients. I know in what situation they live. They're one of the most stigmatized. And to have someone like you globally to help them means a lot. So thank you so much indeed. I say this because of my personal experience also. In 1990, I had attachment in Armer Hansen Institute in Ethiopia and worked for some time on leprosy before I did my immunology master's, actually in preparation for the course. And that's when I had firsthand experience with leprosy patients and in what condition they live and the level of stigma, and not only for the patients, but including for their families. So I have no words to thank you for your commitment, because I know what it means. So arigato gozaimasu. And then the second issue is, again, to what I said in my speech, asking those donors who have suspended funding to UNRWA, we really urge you to reconsider. I think Gaza will be a serious, it's a disaster, but it could even be worse with the suspension of the funding. So we urge you to reconsider. And then finally, thank you so much to the members of the press for joining us, and see you next time. Thank you.